Thanks. Okay, so obviously I can't see you, so I don't know who you are, but I've been told that you are in year 12, so you might be applying to medicine in October. My name's Helen. I'm a urology registrar, so I'm a junior doctor in urology, training to be a urologist, which is a surgeon that deals with kidneys, bladder, prostate, and mainly the male reproductive organs. I left medical school in 2009, so I'm quite old. So some of the stuff I don't know about what's going on in medical school applications and things like that. But I just wanted to give you a flavour of what my life is like, some of the good bits and not so good bits, any advice which I think might be useful to you at this stage, and just some interesting articles about surgical training in particular. I think we'll try and stop maybe 2 or 3 times for questions. So if you have any questions about the bits that I'm talking about, I can try and answer them, and then maybe we'll do more questions at the end. So the first thing I wanted to do was to have a little case study. I don't know if this will work, maybe not, but it's something that you can maybe think about if you don't want to write in the answer. All good medical presentations start with a case study. So in medical school, you'll go through a lot of different case studies of patients and trying to figure out what happened to them. So this, I'm going to show you a CT scan of a 33-year-old man admitted to the emergency department after a motorbike accident. So this is a CT scan, so it's like taking lots and lots of x-rays. And this is a scan of the man's pelvis. I won't say too much more, but if you could have a look and think about maybe what might have happened to him. I'll ask our organizers if they have any ideas.
Yeah, so we have the chat up here, so
right.
And we've asked people to post their answers in the chat, so we'll read them out. So we're seeing bone rupture, hip fracture, testes ruptured, pelvic bone fracture.
Great. So you're right, something's definitely fractured. This is the pelvis here, if you can see my mouse, so that's definitely fractured. And this is the brightness of bone. So bone is quite white. And this bit down here is also bone. And it's not his testes that has ruptured, but in fact, something else that has happened that's extremely unusual. And it might give you a clue if you look to see that he also had a hard swollen scrotum and a painful left hip and a left leg that's rotated and slightly shortened. So this will give you more of a clue. So what's happened is that he came off his motorbike, and with high velocity road accidents, you can have hip fractures. And you can see that this is what the hip bone normally looks like on the right hand side. On the left hand side, it's broken into at least 3 different parts. And this part of the pelvis is also smashed up. And what's weird is that part of his femoral head, which is the hip joint, has actually gone into a scrotum, which is this white ball that you see here. This is bone in his scrotum. So normally you do not have any bone in your scrotum, you have your testicles in your scrotum. So this is vaguely urological. And you can see, apologies, there's some nudity here, but you can see that what they actually had to do is to fish this bit of bone out of his scrotum and then put it back in the right place and then put all these plates in to fix his hip bone back together. So this gives a flavor of how we cases and the kind of strange things that can happen in urology. As you can imagine, people doing strange things and sticking things where they don't belong. And this is definitely one of the strangest case studies in urology that I've ever come across, which is actually published in the New England Journal of Medicine, which is a respectable journal. So moving on to a typical day, I thought I'd go through first. In medical school, they probably want you to have an idea of what do doctors actually do, and for you, your own information to know what a typical day of a junior doctor in surgery might involve. So if you do medicine, then your day will usually start at about 9. Unfortunately, if you do surgery, your day starts a bit earlier because the operating list technically starts at 8 a.m. So you have to get to the hospital before 8 a.m. to see the patients. So you might have up to 10 patients listed for theatre that day if you're doing an operating list. So you'd have to arrive between about 7 and 7:30 to see all the patients who have arrived, having not eaten or drunk anything the night before to prepare for their operation. And you go and take their consent, where you explain to them everything to do with the operation, and you get them to sign a form to say they agree to have the operation. And then you check over, you might never have met these patients before, so you have to know them, know their medical history, figure out what kind of operation exactly they're having. And then at the same time, there's a whole team of people in the operating theatre who prepare everything. So they take out all the sterile equipment from the packs, and they go through what equipment each patient might need. And then generally we sit around in the anaesthetic room at about 8:15, and we do the team briefing, where you go through each of the patients and you try and anticipate if any unexpected things will happen, whether you need any blood to be ready, what kind of equipment you need to get out, and what kind of operation you do, how long you think each will last. And typically the whole theatre team attends this, including all the anaesthetists and the surgeons. So I'll go into the surgical team in a minute. And then you then go back to the ward and see some patients on the ward round, because all the patients that have arrived in previous days that you've operated on in previous days will be on the ward, so you have to go and see them. And typically the ward round does involve talking to patients, but the majority of the ward round is actually done looking at the computer, looking through all the results, figuring out what's going on before you go and speak to the patient. So that's the bulk of the ward round. And typically on a ward, there's maybe up to 30 patients. So it does take quite a long time to do a whole ward round. And you'll have your whole team there with the most junior doctors, the foundation doctors, and then the registrars and the consultant and all the nurses as well. So then the operating list usually starts at about 9. And this is what a typical operating room looks like. So there's many different people that are involved in the operation apart from the surgeon. So here you would have the surgeon, this is the surgeon, his assistant or her assistant here. This is the anaesthetist who stands at the head. So the patient is under here somewhere, probably lying on their side, and the feet will be down here. The head will be up here. There's a screen which is kind of covering the head to try and maintain this sterile area, cover all the drapes. And this is, they're doing a keyhole procedure, so they're looking at the TV screens. This is a scrub nurse, and then all around in theatre there'll be at least 3 or 4 different other people, including the rest of the scrub team who have to go and fetch equipment, and the radiographer who comes and takes x-rays, and maybe the research staff and medical students. So that's pretty much exactly what every operating room will look like. And then just to dispel a myth about robotic surgery, it's not done by a robot. The robot is, you can't really see it here, but it's this thing here with lots of different arms that go through different holes in the patient. And then the people doing the operation are actually sat here. So this is called the Da Vinci system. So there's 2 consoles, and a surgeon and an assistant. And the surgeon sits there and looks at what's going on and operates the robot, which is over here. And then there's another assistant here who kind of feeds things in and out of the patient. So that is a robotic system that a lot of hospitals have now, that we use very often in urological surgery. And the benefit is that you can do very complicated things without just having to use one single kind of instrument on a pivot. This allows 360-degree motion, also 3D vision when you look into this console. So that's robotic surgery. And then this is the kind of stuff that you might see during an operation. So here, this is removal of a bladder. So this is the kind of thing that you're dealing with. You have to learn lots of different anatomy and make sure you don't damage things that you need to preserve. So if you're trying to remove the bladder, you need to get down to it. And there's various things in the way, like your sigmoid colon and your arteries. These are the kind of little instruments that you put into the robot. And these are the various different structures that you're trying to avoid, vessels and nerves, which you don't want to damage in your pelvis. And here you can see you can use little scissors to cut things open and get to things, and clips to tie off vessels, and then a bag to remove any of the cancer specimens that you've removed. And then after your case is finished, you'll go and see the patients post-operatively, tell them what's happened once they've woken up from the anaesthetic. You have to do paperwork, write the op note, do the discharge summary, and then consent the afternoon patients during lunchtime, do the afternoon operations, see the post-operative patients at the end of the day, do more paperwork. When the operating list is finished, you might go to the ward, see some more patients, check all the patients' information for the next day, and then leave the hospital around 6 to 7, unless you're doing on-call, in which case you'd stay until the next day maybe. So obviously all different people's schedules are different, but in terms of what a surgical junior doctor might do, you might have an all-day operating list on Monday, and then Tuesday I have a procedure list where I do kind of looking inside people's bladders to see if they have cancer, which is done when they're awake. Evening on call, 5 till 8. Wednesday day off. Thursday operating list in the morning, clinic in the afternoon. Clinic is just where people come into the hospital and you see them about their outpatient problems, so non-emergency problems that get referred by the GP. And then Friday is a mixture of different things that might happen. So all of these different activities are what a doctor typically does. It's not all about seeing patients. We do have various meetings where we discuss patients in the cancer multidisciplinary team meeting, departmental meetings to do audit and research. You might have to spend your time doing research projects, go to external conferences, and then as a trainee, you have to spend time revising for exams, filling in your portfolio of all the procedures that you've done and attending teaching as well. So that is typically what I do. Before I go on to that, is there any questions?
Oh, that's perfect timing because some questions have just come
Great.
in. So the first question I think maybe I could answer is, do they teach you how to control the Da Vinci robot at medical school? I'm sorry to say that we're not even allowed to touch it. But, well, that's not true. You are allowed to. But is the Da Vinci robot also used in other medical fields like cardiothoracic surgery?
Yes, so the Da Vinci robot, I think urology was one of the first people to use it because the pelvis is a very small space. So it helps to get instruments down there that can be operated remotely. But they use it in colorectal surgery a lot at the Churchill. They use it in gynecological surgery. So that's also in the pelvis. And they have done all kinds of operations with the robot, including esophagectomies and cardiothoracic surgery. I haven't heard of it, but they definitely do keyhole surgeries in cardiothoracic surgery. So it's being used for all kinds of things. Okay, and no, they don't teach you how to use it in medical school, but if you become a surgeon of the future, you will almost definitely use it unless you're doing something like, you know, breast surgery. I mean, even ear, nose and throat surgeons use it to take things out of your mouth. So you'll definitely be using it and learning to use it if you train to be a surgeon in the future.
Okay, doke, wonderful. So is keyhole surgery more widely practiced in urology as well as more invasive surgery?
So actually, urology is very much more of a keyhole specialty. We put all kinds of different telescopes into the bladder and into the kidneys and do robotic surgery. So actually, open surgery is not as common in urology. And I think more and more surgical specialties are going on to robotic surgery, unless it's just at the surface, like if you're doing testicles or bum surgery or breast surgery or, you know, eye surgery, various things that don't require keyholes, then you don't need to do that.
Okay, doke. And then I think the next question is quite related, is asking about, are most surgical specialties moving towards keyhole over open surgery?
Well, it depends. I think within the abdomen and the pelvis, more and more are moving to keyhole. And I think it's something which, I mean, there's now at least 2 different types of robots. So as that progresses, I think it's already happened, and I think it will be a case of justifying whether it's beneficial or not. So they're running lots of trials to see if robotic surgery is actually beneficial for the patient, rather than just using new equipment.
Okay, look, and maybe just the last question for this section is, how long do these surgeries usually take?
Oh, that's a good question.
How do you cope with
So robotic surgery is a lot slower. So if you were to do what's called an open cystectomy, so you take the bladder out by making a big cut in the tummy, then that would probably take 3-4 hours. With a robotic cystectomy, it could take 8 to 10 hours. So things can take a lot longer.
Brilliant. Okay, we'll come back to some of the other questions.
Great, thanks.
Later.
So, I mean, you might have heard about this already, but just from my point of view, I thought it might be good to get an idea of the good bits and the bad bits, just from my point of view. Obviously, it changes for everybody, and having a realistic expectation of a medical career thing that I think they do want to know in medical school. This is a famous picture that was kind of circulated during Brexit. Not that I have any political opinions about Brexit, but just to show that urology teams and the whole team in general is very, very much a team activity, and there's lots and lots of different people that participate in the team, and that's probably one of the good points about working in medicine and in surgery. Contrary to popular belief, it's not all about the surgeon, and there are now lots of very experienced people. For example, you have robotic assistants that can do a large part of, and also surgical assistants that can do whole operations by themselves. So there are lots of very skilled people, and the scrub nurses have to be extremely skilled to work in a surgical team. So in terms of the good bits, the purpose is obviously the main driver, and I meet various people who've had previous careers, and they always come back to this, that they chose medicine because it has a clear purpose. You don't kind of query why you're going into work every day, or if what you're doing is worthwhile. The patients, I mean, there's all different kinds of patients, and when you choose your specialty, a lot of it will be choosing your patients. So obviously, if you want to work with kids or women, then you choose that particular specialty. But for me, I found that the patients, as well as the other surgeons, were the most friendly and nice in urology. That's just my opinion. But in urology, a lot of it is working with middle-aged men. So I happen to like that, and the patients are obviously very rewarding, and you get to meet lots and lots of different people every day. The team, as I've said, I think one of the main benefits of working medicine is you work with people who are very kind of similar to yourself, although the team is very diverse from all different countries and all different backgrounds. They're very similar to you in their aims and their goals and their kind of intellectual curiosity and getting things done and trying to help people out. So I think working with just generally nice, motivated, intelligent people is definitely a perk of doing medicine. Personal development, in some jobs you kind of do the job and you get promoted into higher ranks of managerial responsibility, but in medicine it really is about personal development. You develop surgical skills, medical skills, knowledge. You develop and leadership skills and all kinds of communication skills. So it's a constant journey of personal development that doesn't stop. So it's not just about doing the same job, but it's even when you become a consultant, you finish the training, you will always have some kind of development. It is an intellectual challenge. So if you enjoy that, that is something that medicine is always changing. So it will always be an intellectual challenge. Career diversity, this may be something that medical students, people going into it, don't realize, is that you can actually do a lot of different things. And from doing medicine, you get a bachelor's degree in science at the end of medical school, but a lot of people may choose to go into something completely different. And that is open to you. Just because you do medicine doesn't necessarily mean you have to become a doctor. Once you've become a doctor, you can also change careers, and lots of different opportunities await you. I know that medical students at Oxford can do internships in McKinsey. Not that I'm recommending that, but you can go into pharmaceutical medicine is quite popular, but also a whole diverse range of medical writing, journalism. There's a whole industry around doctors who don't want to be doctors anymore and go and do something else. Job security and flexibility. It is a very secure job, and it is flexible, and when you'll see later in my career progression, it's something that is actually slightly easier if you need to kind of dip in and out or take time out, or you want to go and do some other stuff. The not so good bits, it is obviously challenging physically, mentally and emotionally, and it's something which is difficult to, I mean, it's obviously easy to see why that would be the case, but I think it's difficult to realize until you actually get there. You have to deal with being awake for many, many long hours. You have to remember a lot of things all at the same time when you become a doctor and in medical school. And emotionally, you have a lot of people trying to get your attention and wanting things and trying to make appeals to you, or maybe complaining, or just being quite rude and abusive sometimes. So you have to be ready for it in that way. And there is a long training and a life commitment. So it generally takes about 12 to 14 years to train to become a consultant surgeon from the point that you leave sixth form. And it's a life commitment. And I'll show you later, there's an article about how you do have to be prepared to move house, be prepared to give up your free time and not be able to plan things in your life because of the way that junior doctor rotas can sometimes work. And that's to do with life stability as well. You do have to move around pretty much every year when you're a junior doctor. So for all those years of training, you may not be in the same place. Working in the NHS, work environment, IT issues, various administrative, logistical, infrastructure issues. The NHS is a massive organisation, and it's not the kind of hip, personalised, place that you might be if you go and work at Google. It's not like that, and everything is slightly difficult to get over in terms of bureaucracy. So that is one of the gripes about working as a doctor, is you will have to work in the NHS at some point. Dealing with failure, this applies to all of medicine, but I think with surgery especially, you have to deal with personal failure, for example, failing exams, failure with not being able to treat patients, failure with causing complications during surgery, failure with being able to progress in your medical career, not quite getting where you want to be. It is a competitive environment, and I think it's about dealing with resilience, and personal as well as professional failure is probably slightly higher risk of that than some other careers. Career progression, you do have to jump through several hurdles to progress your career if you want to become a consultant. But as I said, there's lots of other different options if you don't want to go down the traditional career route. And burnout is a real thing, and they think maybe it is slightly higher amongst surgeons. And it's a kind of feeling of exhaustion or mental distance from one's jobs, negativity, cynicism, and reduced professional efficacy. And surgeons might suffer burnout for a variety of reasons, including with kind of the risk of being sued, or the risk of complications, or not feeling like you've done a good operation, and also the pressure of the medical environment in general. So the profession is trying to deal with that and recognizes that is a problem. Any questions about that?
There are some questions that I'm going to compile, if that's okay.
Yeah, good.
I think a lot of people are quite blown away by how much effort it seems, and how hard work it is.
I haven't even gone to the next bit.
So I guess maybe it seems like a million miles away for anyone. Even, I'm about to be a doctor, and it's quite frightening. But I guess, how do you kind of build up the resilience, deal with the long hours, the stress, and how do you deal with the losses of patients, for example?
Yeah, I think it's like a constant learning process, which you start from day one of medical school. I mean, part of it is that certain specialties that are very stressful might select for certain personalities that are better to deal with that. And maybe, there has been suggested there's an element of a kind of sociopathy with people who can cope with the levels of stress and failure and, potential harm to other people. But ultimately, it's about learning from people who are more experienced, learning in medical school and building up the skills. And in medicine, you deal with the same thing over and over again on a day out basis. So you do become familiar with them, and you do become good at dealing with them. So it's training in surgery is all about familiarity, practice, repetition, experience.
Okay. And then I guess the last bit there, how do you deal with the loss of a patient?
So it is hard, because it's difficult to, sometimes you know the patients well, and that is difficult, but a lot of the times you don't actually know the patient that well. In certain specialties, obviously, you know the patients very well, because you have, you know, kind of a very low turnover of patients. But in urology, there's actually a very high turnover of patients. So the number of patients that you're dealing with, it's very difficult to become too focused on one particular complication or one particular death. And it's not something that you will ever get over, and you know, you can't train for that, and and ultimately you feel kind of personally involved one way or another, but I think it's definitely harder in some specialties than in others, and it depends on the circumstances in which they died. And you know, there are patients that you will always remember and think about.
Okay, wonderful. We might leave it the questions for now.
Yeah, good. Right, I'll try and finish on time. So yes, so this is advice, and first I'll start with a bit about the timeline. So this is something that you would also be expected to know if you're going to medical school, but again, it varies for every single trainee, the path at which you take to finish training. And as far as I mean, training's changing all the time, but this is what I've been through. So you'll see that I left medical school in 2009. When you leave medical school, you get a Bachelor of Medicine, Bachelor of Surgery, and some medical schools you also get a separate Bachelor of Science, or in Nottingham they have Bachelor of Medical Science, which is the same as a standalone kind of bachelor's undergraduate degree that you would get in a science subject. So some people do choose to leave medical school at that point after about 3 years, and maybe go off and do maybe a master's or a PhD in research, or maybe go and do something else different completely. After medical school, you enter into the foundation year training. So it's called FY1 and 2, and that lasts for 2 years. So that's where you rotate through different specialties: surgery, medicine, GP, pediatrics, and to some extent you get to choose where you go and what you do. The bits highlighted in red are where you have to apply for it. So you compete with other people to apply for a particular set of jobs or a particular location that you want to go to. And then after that, if you want to do surgery, you apply to something called core surgical training, which also lasts for 2 years. And this is where you rotate through different surgical specialties. So for example, general surgery, urology, neurosurgery, vascular surgery, all different types of surgeries, but generally you would rotate through the things that you are interested in. So by this point, it is kind of useful to know what kind of surgery you want to do. So for example, I did 18 months of urology and 6 months of general surgery. During this period, you would take the first postgraduate exam, which is the medical member of the Royal College of Surgeons exam. So that's a MCQ exam plus a kind of viva exam, and you need that to be able to go to higher surgical training, which is called registrar training. That's now called ST3, and this goes on for 5 years. So you go ST3, 4, 5, 6, 7. So you could theoretically finish all of this after university within 9 years. So you can become a surgical consultant at about 32, and there definitely are some around who are 32. So that might be the point at which you become a consultant. However, I took some time out to do a PhD and then had some maternity leave. Then I did some more registrar training. Then I did a year of something slightly different. And this is again what I was saying about flexibility. I did half-time training, half-time as a research fellow. And then I took some more maternity leave, and this brings us up to this year. And then this year I'll be going back into registrar training to do the last 2 years and sit the next postgraduate exam, which is the Fellow of the Royal College of Surgeons exam, which is again another MCQ and a viva, which I'll take in June and November. And then once you've passed that, you're eligible to have what's called CCT, which is completion of a certificate of training, which means that you're eligible to become an independent surgeon or a consultant. Most people would take a fellowship at this point. Usually you can go broad, but you do a year where you concentrate on doing the type of operation that you plan on doing as a specialist, and then finally you might reach to be a consultant, and then you apply for a consultant job. So in terms of seeking opportunities, if you're interested in surgery at medical school and as a house officer, those first 2 years out of medical school, At medical school, you could may potentially choose a medical school that maybe focuses on anatomy and dissection, but that's not essential. Or you could take opportunities to learn more about anatomy and dissection. When you're in medical school, it'll be attached to a hospital. So when you start doing your clinical rotations, you can talks at the hospital and what's called grand round, where they have a big presentation each week of a surgical presentation, which, for example, happens in Oxford, which medical students attend. You can choose in medical a special study module, so you can choose to take time to go and join a surgical team or do a specific surgical project, which is your choice, which you organize. Most medical schools do that. Most medical schools have a surgical society which will organize events and talks. So, for example, at Oxford, it's the Hugh Cairns Society. And they also have a mentor scheme down here where you can buddy up with a surgical trainee. There's various surgical skills courses run for medical students and house officers. You could revise for the first part of the college exam when you're a house officer to prepare for application to higher surgical training. In medical school, you can choose a surgically orientated elective. So the elective is a period of time in medical school where you go abroad. And for example, I went to India and Nepal. I didn't do anything surgical, but you can choose to join a surgical team somewhere else in the world. And you can enter a surgical prize or award, and there's lots of them around when you're medical students. But the most important thing, I think, is when you're on your clinical rotations in medical school is to talk to the junior doctors in your surgical attachments, find out who are the keen trainers, get information about, what they're doing, how they plan to become surgeons, and any consultants that are keen to help you or train you or join in projects. The other thing that I would recommend is to look on Twitter, because there's a lot of medical Twitter accounts and they always have some good up-to-date information about what's going on in the world of surgical training or of medical schools. So for example, I get a lot of my information from Twitter. This is the project that Remy took part in with me, and I find out about it on Twitter. I get all the updates on Twitter about how the research study is going. You can look for jobs on Twitter. Jobs are advertised on Twitter. I get my medical research info. So they do these kind of research summaries that are published. There's also things for medical students with events. So all the news first comes out on Twitter if you're looking for any events or opportunities or good people to get in touch with to find out about medicine or surgery. This is the Royal College of Surgeons of Edinburgh. So all of these have career advice for medical students interested in surgery. They may have courses for medical students as well. This is the Royal College of Surgeons of England website. So this is the professional body for surgeons. And this is a whole student section as well. And they also have a course for students and health professionals. And if you want to find out about what kind of application ratios for jobs, and you can look on the Health Education England website, which advertises all of these year by year, so you can see how competitive this is. So for example, core surgical training, to get into that first stage of surgical training, it's probably between a 2:1 to 4:1 ratio, but it changes every year. When I applied to urology, it was a 4:1 ratio to get into registrar training. So out of 120 people applying for registrar training, they'll offer about 20 jobs each year in the whole country to enter registrar training. So I'll stop there. I might not have time to do any more, but I can take some questions.
Oh, yes, please. So a recurring question that's come up a couple of times actually is, why did you choose surgery? And then it might also be helpful just to explain the difference between the surgical pathway and the medical pathway. Just I'm not sure.
Okay, yeah. So I don't really know why I chose surgery. I think it was more that I had a really good rotation as a house officer, foundation year 1 in Derby, and I met some really nice people on the team, and I thought the whole specialty and the patients and the team were very nice. So I chose it quite late, which is why I didn't really do anything surgically orientated at medical school. And I think when you choose a specialty, it's about how you think you will fit in, and it is very personality dependent and situational. It just is an accident. You know, I thought I went into medical school thinking I'd do psychiatry, which is obviously extremely different from surgery. And then I did my psychiatry rotation and I didn't like it. So I thought, well, I'm not going to become a psychiatrist. But you know, throughout all my rotations at medical school, I never was particularly interested in surgery. And I think it's just, at some point you do have to make a choice and you choose a thing which you think you will fit in best and like the most. What was the second question? I've forgotten.
The second part was, I was just going to say, if you could just explain.
Oh yeah. So there's very many different pathways, but for the medical school, everyone does the foundation year, so 2 years, where you rotate through medical and surgical specialties. But after those 2 years, so in F2, you have to make a decision, basically, whether you want to do medicine or surgery. And if you do medicine, you then enter into core medical training. So it's like the equivalent of core surgical training. And you do 2 years of that. But however, there are many different specialties. So if you decide to do pediatrics, you would then enter into pediatric training or radiology training. So you basically compete for a job which has rotations in medicine or surgery or pediatrics for 2 years. And then after those 2 years, you then compete for another job where you only do one particular specialty. For example, urology or general surgery or anesthetics or radiology. And then for the medical specialty, you have to do specific medical exams that are to progress. And then for surgery, each specialty have their own set of exams, and some specialties have a lot more exams than others.
Thank you. So a two-parter. So life working in the NHS. There was a question about that, if you could comment. And then what's the best and worst experience you've had as a surgeon?
Okay, I don't know. It's put on the spot. I probably won't be able to answer. Life in the NHS, I think something that you won't realize until you finish medical school and maybe go into the professional world is that you will have people who become doctors and then people who perhaps work in the private sector. And working in the public sector is extremely different to working in the private sector, and it's got a very good job security. You know, you've got a very set pay scale, you've got a good pension, and you've got good holiday and very many perks like that. But it's not quite the same kind of perhaps meritocracy as it is in the private sector. So it's just a case of working in the public sector and some of the frustrations that go with that. And you know, this is the stuff that doctors just moan about all the time, and things that kind of make your life difficult because there's so much paperwork, or you have to pay for your parking space, or they won't let you take holiday when you want to, and you don't find out what you're doing until a week beforehand, and etc., etc. But obviously every job has its frustrations, and I can't really say what it's like to work outside of the NHS because I've worked in it for so long. But you know, every massive public organisation has its good points and its bad points. What was the second part? It was, best and worst things. I think the worst things are definitely when you've cocked up basically and you've done something wrong and you feel extremely bad and you feel incompetent and generally have a lack of confidence, and or you don't get on with the people that you work with, or you know, you just feel bad because you haven't done your job very well, and it's, you know, you've been put in a stressful situation, and then probably and then seeing bad things happen to people is not very nice. And then probably the best things that I've experienced are when you know, you've just had a good day and you've done a good list, and in one day you've helped 10 people that have been waiting for a year to have this operation, and you've managed to fix their problem for them. And that's the satisfying thing about surgery, is that often you do something and you fix it, and it's a quick kind of solution to something.
Okay, great, thank you. Then there's a question about research. So how do you get to do research in surgery?
That's a good question. So in medical school, you may choose a medical school that has a research degree. So you can start there, and often that kind of starts your path towards it. For foundation, you can apply for something called academic foundation rotation. So it's Academic Foundation Program, AFP, where you get to do a specific research project during your foundation years. So you might have, for example, 4 or 6 months of your foundation rotations just doing research. As you progress, there will be opportunities to do research projects, but you do have to do them in your own time, so it can be quite time consuming. And then later on, after academic foundation or foundation year, you can apply for the ACF, which is the academic, I can't remember what it's called, but basically you then go into a surgical training program, but you have 6 month blocks where you do surgery, where you do research. So the whole training is stretched out because you're taking more time to do research as well. And then from there, you can apply to do a PhD. So there are lots and lots of different opportunities to do research, either ad hoc on your spare time or as a formal program where they train you to be an academic surgeon. And there's information about that on the various websites that you can find about academic training during surgery.
Okay, great. And then maybe the last question, just given the time, that's come up a few times, is how do you deal with your personal life and with a career that's
yeah. It is very hard, and I think that's the thing that people do find the hardest, because it is a vocational career and it does kind of take over your life and your relationships and your decisions about life to a certain extent. There are very many different careers that you can take in medicine, which maybe are more stable or more predictable, take up less time. So you know, it depends what you want. You should definitely find out about those. And you can always change your mind. Some people do surgery and then find out, you know, the lifestyle is not suitable and they go off and do GP, or they go off and do something different. But basically, you need to have time for yourself and have very supportive people around you. Once you have children, you need to organize some extremely good childcare.
Okay, great. So I might pass to Remy.
Thank you, Helen. Do you have much more of your talk left? Because we're recording. If you
okay.
I mean,
it depends. Do you want me to finish? It's just some stuff of interest. It's not particularly, if I've kind of covered what everybody wants me to cover, then I won't necessarily.
Well, how about, if you're happy, Helen, please do share some interesting articles. I'm sure the people here will be interested.
Don't feel you have to look.
Yeah, no, it's recorded anyway. So if any of you guys would like to go, you can see it later on YouTube. So please go ahead.
And these are just some things that I thought might be of interest. Maybe they're only interesting to me. I don't know. Obviously, I'm very old, so I don't know what people are thinking these days. But for example, if you look at actual research that has been done into medical careers and why people choose to be surgeons, and there's a lot of research that's been done about that, you can see that in terms of what medical students want to do, actually 20%, although there was only a response rate of 5% of medical students, but 22% said that these medical students did not intend to work within the NHS for the majority of their careers. 19% intended to work abroad, and 3.4% plan to use their medical degree in another profession. So you can see, even as medical students, they're already making decisions about their future career, not necessarily along the predetermined career path. And of the alternative careers considered by medical students, here is a wide variety. And there have been some, you know, medics and surgeons in Oxford who have left to set up companies and do entrepreneurial activities. So it's very possible that you can pursue lots of different other careers. In this survey, of the people who think they might leave the NHS or might not intend to work in the NHS, 66% said it was on the current state of NHS working conditions and 20% on work-life balance. So that is definitely a consideration. Medical students often like to go abroad. So in terms of opportunities, you can go abroad during your elective, which is usually something like 1 to 2 months during medical school, and you have to organize it. You can go abroad people, my friends, have gone abroad for their foundation year. So you could, I don't know if this is still possible, you can do one of your foundation years in Australia, for example, and that would count towards your training. You can go abroad between foundation year and core training to just have a holiday, or you know, some people take that time to get married, and that's actually, you know, reasonable, because it is hard to get time off work, or you can go abroad and do more experience. But some people do go abroad permanently, and some of my friends have done as well, where they've done the whole of their training abroad, for example, in emergency medicine or surgery, and these are some of the countries that people go to. I think you are obligated to work in the NHS during foundation year 1 and 2, but after that you can go and do what you like, basically. So does the choice of medical school affect a student's likelihood of becoming a surgeon? Surgeons are very interested in what kind of people become surgeons. Maybe it's a vanity thing. And you can see that some medical schools have a significantly higher rate of people ending up applying for surgery training, core surgical training, that's CST. Oxford is actually below average. About only 8% of their medical students apply for surgery training, whereas, for example, you can see Nottingham and Imperial are above average. So some medical schools have, all medical schools have different types of rotations and curriculums. So some medical schools may focus more on surgery than other medical schools that have more opportunities for that. Reasons why you might not pursue a career in surgery. So again, these are some of the things that I've talked about in terms of lifestyle, exposure as a student, competitive, surgical culture is too aggressive. These are perceptions of people. Other specialties have greater patient contact. Maybe that's true. Maybe patients are asleep some of the time. Poor training is too long, uncertain. I have sufficient manual dexterity. It's too stressful, bad experience as a medical student, not interested. And then this is what you kind of talked about, is the non-monetary costs of training. So this is working long hours, personal financial burden required to train a surgery, the cost of completing mandatory postgraduate requirements in higher surgical training reported to be between £20,000 and £70,000. Many other factors, including low workforce morale, poor work-life balance, contractual issues. These won't mean very much to you at the moment, but these are some of the things that we do talk about within surgical training, and then kind of a survey that they did for the impact of surgical training, and you can see some people have to move house a lot of times to work with different rotations, but that can happen in non-surgical specialties as well, or that, you know, you've had a negative impact due to medical training. And very recently, just the other day, the Royal College has published a report on diversity and has recognised that there are difficult issues within surgery and surgical training and lack of kind of diversity in the leadership, and also fitting in with flexible working. They're going to launch a new effort for flexible working for surgical parents, and, you know, there's statistics on the kind of potentially racist and sexist problems to do with surgical training and surgical leadership at the moment. So it's something which is in development all the time, and it's, you know, recognized features of the positives and negatives of doing surgery, and it's not something to put you off, but it's something to have a realistic viewpoint. But by the time you graduate, it might have changed a lot by then, and that's all I have to say.
Thank you so much, Helen. Yeah, I hope it's getting better. I hope to be in your position one day, and I hope there are people in this chat who will also be able to pursue surgery in the future. Just because we're already over, I won't. We'll leave some of the remaining questions, but thank you so much again for joining us, and thank you all for coming. We'll